Good afternoon and welcome back to Grand Rounds. If you could please remember to fill out your attendance records and also fill out the program evaluations and give us any ideas that you might have in regards to future topics and future speakers. Our speaker today is Dr. Bryan Warme. Dr. Warme is an orthopedic sports medicine specialist. He did his orthopedics residency at the University of Iowa and then did his shoulder and sports medicine fellowship at the Hospital for Specialty Surgery in New York, and he's here today to update us on some interesting and exciting new procedures in shoulder surgery. So please join me in welcoming Dr. Warme.
Thank you. Thanks, Dr. Hallberg. It sounds like my mic's working, so I think we got this all working. Welcome. I hope you guys get to enjoy this and learn a little something. This is really one of my passions is shoulder arthroscopy, and basically, during my talk today, I'll kind of go through these 4 topics and try and hit on what's new, what we're doing differently now, and, you know, kind of showing you sort of how things have changed over the last decade or so with regards to old dogma versus new dogma and what the research out there is to support it, and kind of give you an idea of some of the things I learned in fellowship and things that I've been doing here since I started. So I'll start with a case report. This was probably my second week of working here. A referral from one of my partners saw this gentleman, and basically what I would point out is that he had severe wasting in the supraspinatus fossa and the infraspinatus fossa, and profound weakness in his rotator cuff exam. So supraspinatus fossa is kind of on top of your shoulder, and then the infraspinatus is right below the spine of the scapula. And this gentleman didn't have any injury that he could recall. He just basically progressively got weaker and weaker and weaker to the point where he wasn't really able to use his left shoulder at all. This is a web picture. This is not the patient, but it kind of shows you this wasting phenomenon. So here's the infraspinatus fossa, and my patient was actually even more profound than this, where you could basically see the entire bony landmarks of the scapula here, where they had just kind of wasted away. So at that point, you know, I was concerned about the rotator cuff because he was so weak. I was a little bit suspicious because there was no injury that would, would be suspicious for a tear. At that point, we ordered an MRI, and the rotator cuff itself was actually intact, but the MRI noted a slap lesion in the labrum, and then paralabral cysts tracking along the scapula. So I'll show you pictures of those here. So this is his picture. You can notice that his rotator cuff tendon, this is the supraspinatus tendon intact. This is basically the frontal plane or the coronal view, and this is his rotator cuff coming in, and it's intact all the way down. Going into this, I anticipated seeing a tear in here based on his exam, but he did have a tear in the labrum here, and then fluid from the joint. When there's a tear in the labrum, just like in the knee, which when you can get Baker's cysts, you can get them in the shoulder too. And so here in the shoulder, fluid from the joint sneaks through the labrum, and it kind of works as a one-way valve. And so you can get fluid coming out this way, and that fluid was tracking along here. If you look, these are axial views, so 2 separate slices, and this is quite an extensive fluid collection here. So these are both bird's eye views looking from above. This is a sagittal view, so we're looking from the side like this. If you look at where this cyst is here, it's right in this area. So this is the scapula, the glenoid, and here's what we call the suprascapular notch. And there's a transverse scapular ligament right here. If you look closely, there's a black dot here and then some gray fuzzy stuff here. So artery and nerve. So suprascapular artery and nerve transverse the scapula or the shoulder blade right in this notch. So some of that fluid had actually made it all the way back. Fluid made it all the way up there and caused a compression neuropathy of the suprascapular nerve. The 2 muscles that nerve innervates are the 2 muscles where he had profound weakness and wasting. If you look at this sagittal view, here's the supraspinatus, and then here's the infraspinatus. And I don't know how the light is projecting, but if you look closely, I think you'll agree with me that you can see there's a difference in the color on the MRI. It's darker in the teres minor compared to the infraspinatus. And if you look at here, the subscapularis, definitely there's a color difference between the supraspinatus and the infraspinatus, and then the adjacent subscapularis and the teres minor. This was what I saw, which is evidence in my mind of MRI denervation atrophy in those two muscles. So I sent him for EMGs, and Dr. Acosta did that for me, and sure enough, the supraspinatus muscle and the infraspinatus muscle, both supplied by the suprascapular nerve, were positive for changes. So just to review the anatomy a little bit, here's the suprascapular artery coming in that goes over the top of this transverse scapular ligament, then the suprascapular nerve goes underneath that. So this is the transverse scapular ligament here. This is the spinoglenoid notch. Our gentleman, in this case, had compression here, and this is where the cyst formed. Another common location for compression of this nerve is at the spinoglenoid notch. This is very common in volleyball players from slap tears and paralabral cysts from their overhead and the spiking. They often get a cyst right here. If the cyst and the neuropathy happens right here, that would just affect the infraspinatus and not the supraspinatus. So there is my mic still going? I think, there we go, okay. There is some variable morphology of the suprascapular notch. And so the one that is the most difficult is if there's actually a bony bridge and there's not actually a transverse scapular ligament, but actually a bony bridge. You can imagine when there's bone circumferential around a nerve, that does create problems when there's a compression effect or a mass effect, even more so than if it's just a ligament. But I was kidding my partner, Dr. Friedrich, the other day that I do carpal tunnel surgery in the shoulder. So basically what I do is I dissect my way with, arthroscopically, I'll dissect my way back here, find this ligament, and then I just snip that and kind of debride that to free up that nerve, and that's how we do the decompression. So it is it's analogous to the carpal tunnel release, where you're in the wrist, you're releasing the transverse carpal ligament. Here I'm releasing the transverse scapular ligament. So again, here's where this person had his cysts forming, and the nerve goes underneath the ligament. You can see here's the cyst and here's the ligament over that, and some nerve tissue right there. So, and then here's their sagittal, again showing the color difference or the MRI evidence of denervation atrophy in the supraspinatus and the infraspinatus. More commonly than having a compressive effect, it's also very common to have compression at the spinal glenoid notch also from a rotator cuff tear that leads to medial retraction of the muscle fibers, and that medial retraction can also bring the nerve with it and then compress it against that spinal glenoid notch. And so that's another way. So if this guy had a rotator cuff tear, which he didn't, this is completely intact and there's no medial retraction of the fibers. But one way to decompress that nerve, if we think that's what's causing it, is just to simply fix the rotator cuff, and that oftentimes will bring that nerve back with it and pull it off that bony impingement. But since he had a compressive neuropathy from cysts, I had to actually go there and decompress it. This is one of the papers that's come out recently from Harvard that looked at whether or not this suprascapular nerve can recover, this is a very new procedure. It started over in Europe and is done most commonly in France, but the literature strongly suggests that the nerve can recover if you do the surgery or the operations early enough. I'm going to skip over that. This is one of our academy sort of clinical indication guideline type papers that basically just describes how to work it up. So basically, we had the plain radiographs, we got the MRI, and he had no rotator cuff tear, but he did have mass compression. Then I went on and got the EMG studies, and it's worked really good here. The neurology department's been great about isolating the suprascapular nerve for me. I've been here since August, and I've done this 3 times now, and so far it's worked. The one thing I would tell you is that when you see denervation changes on the MRI like this, there's no way for me to predict whether or not that nerve can recover. But at the very least, if we decompress the nerve, we can hopefully prevent it from progressing. And that's, one of my areas of interest is trying to help work with my fellowship group that I worked with and trying to figure out how to predict whether or not a nerve can recover. As you know, in the carpal tunnel, if the nerve compression has been going on long enough and there's enough muscle wasting, it's possible that releasing the carpal tunnel would not give you a reversible effect on the nerve. So that's one thing that we're not able to predict completely whether or not the nerve will recover. But I often tell patients, one reason to do it is to make sure that what function you have we can try and preserve without it getting any worse. This is a special X-ray view. It's called the Stryker notch view. This is typically used for Hill-Sachs lesions out here, but it also gives you a pretty good look at that suprascapular notch as well. So this is the view I look at to see if there's a bony bridge across there or not. So this is sort of the algorithm. And this is kind of where we ended up with this patient that I'm showing here today. Now the open decompression has been around for a long time, and only in the last decade or so have we started doing this arthroscopically. So this is sort of the setup for me arthroscopically with portal sites. There's 2 accessory portals. These are called Navisor portals, and then my other portals are out here along the shoulder standard. I use a blunt obturator to protect the nerve underneath, and then I do my transverse scapular decompression with arthroscopic scissors. So here's the anterior part of the shoulder, posterior, lateral. The patient's head is up here, and this is sort of just drawing out the tract of the nerve, and it's about right in here where that notch is and where it can get compressed. So this is actual pictures from the case that I did. Here is his labral tear, and that's where that the fluid from the joint was sneaking out and creating those cysts. So the first thing we have to do is fix the labrum. So here's the labrum now fixed back down to the glenoid. And then we dissect out towards the ligament. So here is the notch. This is the nerve transversing under the ligament. And then this is after I've released the ligament here, and the nerve is now more free and now decompressed. So this guy I did about my 3rd week or so of practice here, and I've seen him for final follow-up, and I don't know if I got lucky or if things went really well as we would hope, but he's got full strength recovery back. He's back. He has a little bit of a laborious job, and he's doing that without any problems. And I tried to talk him into doing an EMG afterwards, 6 months out, to see what the nerves looked like. But in a private practice setting, it's hard to justify that with insurance, and it was hard to convince him that it was worthwhile doing because you stick needles in the shoulder to get that information. But needless to say, on physical exam, he's doing great, and he thinks that he's fully recovered. So jumping from suprascapular neuropathy now, going to rotator cuffs, talk a little bit about what's new in rotator cuffs. Does anybody have any questions about the suprascapular stuff before we move on? Feel free to interrupt me at any time. Go ahead. They have pain from impingement a lot of times, but it is a motor nerve, and it's motor just to the supraspinatus and infraspinatus. So that's just to this muscle and just to this muscle, and that's it. The pain that they have in this gentleman was probably from the labral tear that he had. So now on the rotator cuff tears, historically rotator cuff tears have also been treated through an open technique. Our arthroscopic techniques have gotten a lot better in the last couple of decades or so, to the point now where, at least in my mind, I feel like I can at least see the tear and see the injury much better with the scope than what I could open. And the tools that we have now are better, and we're able to get to places through the scope, I think, that we can't get to through an open procedure as easily. So this is a 48-year-old gentleman. He was a truck driver and basically was really struggling to haul his loads and unload his loads, that kind of thing, and it was keeping him up at night. In my mind, with shoulder pain that we think is impingement or cuff type pain, if the patient is waking up at night in pain, then I think that at that point it's affecting their quality of life enough that we should look into it more, especially if they've already had an injection or tried physical therapy and they're continuing to wake up at night. That, for me, is an important question I ask patients, because that reflects to me their quality of life and how much this is affecting them overall. And this guy had that. We had done PT and injections without him getting better, and so we got the MRI. This is a picture of his MRI. So here's the supraspinatus muscle belly, here's the tendon, and here's where it attaches in the footprint, and here it is retracted to basically the middle of the humeral head. The muscle quality on the sagittal was, in my mind, considered normal. So on the last case, we had denervation atrophy, where the muscle quality became much lighter on MRI, which would suggest that the nerve wasn't, or the muscles weren't being innervated. Another thing that can happen is that once a rotator cuff tears off its footprint, then that muscle is no longer attached, no longer working. It can undergo atrophy and fatty infiltration. You see a little bit of that right here. Is a little bit of fatty infiltration. There's a couple of different staging schemas out there, but basically if you have good muscle above the top of this Y, that would suggest that the muscle quality is still good enough that if you do repair it, that they would get return to function. And so, in my mind, this guy was a good candidate for trying this. He had failed physical therapy, he had failed injections, he's got a large tear, he's unable to really do his work comfortably. Two things I wanted to show you that are worth looking at from a primary care perspective on this is that when you do have a massive rotator cuff tear, if it's big enough, you have superior migration of the humeral head. In this case, the gentleman's humeral head is still located nicely on the glenoid, but if you look close, there's a lot of sclerosis right here on the edge of the acromion, and basically that is where he's articulating now, because the rotator cuff tendon is over here. There's no soft tissue between here and here, so when he comes up into abduction, he's actually articulating against the acromion. You see it a little bit here on this side too. So here's a little bit hard to see, but this is the shadow of the humeral head. And then this is that part of the acromion that you see right here. This is called acetabularization of the acromion. So once the humeral head is supposed to only articulate with the glenoid, but once it starts articulating with the acromion, because there's no rotator cuff there, then you get those changes. So that's something that, it's just an interesting finding that would suggest that this person probably has a rotator cuff injury and that he has had it for a while, the acromion is undergoing changes that you can see on X-ray. I threw one paper in here about all arthroscopic versus mini open. At this point, what's the difference between doing an open rotator cuff versus doing it arthroscopically? The outcomes are the same long term, and the benefit of doing it through the scope is that are a couple. Number one is that you can see the rest of the joint. You can evaluate the labrum and the glenoid. And then two is that it's 3 or 4 small poke holes, and they recover a lot faster. In my experience, the literature would tell you that open rotator cuff repairs take 6 months to recover, and that's what I still tell patients is that we should plan on 6 months. But in my experience in fellowship and since I've been here, there's still a spectrum, but in general it's much less to where they're back to work and feeling really good. I should caution you that it is a spectrum, though. I have patients all over the board, some patients that are struggling at 6 months and some people who feel great at a month or two. So it's a little bit difficult to tell them, again, what to expect, but in general, I tell them plan on 6 months, plan on this hurting a lot. In general, rotator cuff surgery is one of the most painful surgeries that we as orthopedic surgeons do, and I kind of prep patients for that by telling them that they're going to hate me for at least a week because it is painful surgery. Dr. Buck did mine back in the day. So just to point out, this is a level 2, which is as good of research as orthopedics can get to. A level 1 is a completely randomized, completely blind study. And in orthopedics, when you're operated on real in real patients, and in orthopedics, you can't do that level of and that quality of research, I would argue. So this is as good of research as we can get to in orthopedics is the level 2. So these are arthroscopic pictures of what this gentleman's surgery looked like. I'm up in the subacromial space, so here's the humeral head. Glenoid is down in here. This is the rotator cuff tear. This is the footprint where it attaches. And you can see some muscle fibers of the supraspinatus tendon here. So in 2013, we've got really awesome tools. And basically this is a tool that passes suture through the cuff through a needle, and then I'm able to weave a figure of 8 stitch through that to bring that together side to side, but then also bring it out laterally. So this is a large to massive rotator cuff tear. Anytime you can see down into the joint when you're in the subacromial space, it's a very big tear. So this is a relatively large tear that we were able to fix through the scope with 1 suture and 1 anchor. This is collagen embedded suture, and so it is, biologically it's as compatible as we can get with synthetic material at this point. We're also, a lot of the implant companies are coming out with knotless technique, and so this one was a knotted technique that I tied, but we're also doing it so that they're knotless, and so you don't have this free ends of knots that could be a source of impingement type inflammation. So the bottom line on this guy, truck driver, back to work, I'm giving you all cases that have all gone well. I have cases that haven't gone well too. I'm a human like anybody else, but this guy's back to work and doing great. And I was able to actually do this through 3 little poke holes, as opposed to what would have been a large open incision and a lot of recovery. Third case. Any questions on rotator cuff stuff? Basically, I just wanted to highlight that we can see a lot and do a lot through the scope that we weren't able to do 10 years ago. And I think that this is probably the future, is the arthroscopic versions of this, for the reasons I already mentioned. Acromioclavicular joint. So here's the acromion, here's the clavicle. These bones are supposed to line up. This is what we call a shoulder separation. So the shoulder separation is the injury here. Shoulder dislocation is when the humeral head and the socket, the glenoid, become dislocated. So that's a dislocation here. This is a separation here. Most of these shoulder separations we can treat non-operatively, but when they are significant, as in this case, there is a good surgical indication for doing that. In this case, you can see that this clavicle has migrated superiorly all the way to the subcutaneous tissue. This is the deltoid fascia. Here's the trapezius and the trapezial fascia. And I don't know if you can see that from where you are based on light, but he has penetrated through that fascia. When you penetrate through that fascia, you do predictably better if you fix it. So this is an acute injury from a guy that was skiing. The right dominant shoulder. He's an ROTC guy at Iowa State. This is a little bit of a review of the types of injuries. There's 6 types. These types down here are the more severe ones. And the types up here, the type 3, are the less severe ones. Usually these can be treated non-operatively, and these all have surgical indications. The case that I'm showing you today is a type 5. This is the majority of the ones that are operative. There are some type 3s that you can fix, and in general I don't fix the type 3s unless on a chronic basis they're still bothering them. If they're bothering them 6 months out from a type 3, then I'll offer them surgery, and I'll show you a picture of what that looks like. So this is the best way to really diagnose how bad this separation is one is looking at the muscle and the deltotrapezial fascia and if it's penetrated through or not. Then the other is to compare it to the other side. So we call it an AC separation because it's this joint right here that separates, but the most important ligaments that are injured that allow that separation to happen are between the coracoid and the clavicle. So the coracoclavicular ligaments are right here, and then the AC ligaments and the joint capsule are here. So the measurement we do is we compare those side to side on the same film. So this distance was, roughly 8 millimeters. This distance roughly 22. If it's more than double or more than 100% displaced, that by definition is a type 5 injury, and those are the ones that predictably do better if we fix them. So it's very common to have with a AC joint injury a concomitant slap tear or the labrum, and because he was in ROTC, he wanted to be able to tell his officers what to expect from surgery and how soon he could get back. Otherwise, I typically don't get MRIs because I'm going to put the scope in and check it out anyway. But he needed to tell his officers and supervisors how long he was going to be out. This just showed, this is the clavicle, this is the coracoid, here's where the CC ligaments used to be. There's no chromium in this slice, but this is the disruption of the AC joint capsule and ligament there. So I'm going to show you a little video of, it's an animation of how we do this arthroscopically. So just to orient you here, collarbone or clavicle, humerus and head. Here's the coracoid coming out. Here's the shoulder blade. This will rotate. These are portals that we put in through our portal site. So there's a skin incision here, or a portal site here, and then a portal site right there. So this is a targeting guide, just like similar to what we use in ACL reconstruction. But again, this is all through the scope. Drill through both the clavicle and the coracoid. And now we pull out the drill, and now there's this cannulated sheath. Pull a suture retriever through that. And then shuttle in our fixation device. So this is suspensory fixation on the coracoid. And now we reduce it and put a suspensory fixation on the clavicle, tie it. This is that same collagen-embedded suture material that I used in the rotator cuff. It's very slick. We can do it through the scope, and I've done this twice now in practice with this technique. Once with the more robust technique. I'll show you that next. But this kid's been very happy. He is doing well, and I anticipate he'll be able to do basic training this fall, or sorry, this summer. So that's the AC reconstruction. This is what I would do in the acute setting. Here's some pictures of it. Here's dissecting down to the coracoid so I'm looking medial, and I'm from the lateral position, drilling through the coracoid. Now I'm passing that collagen suture through, and here's that suspensory fixation on the undersurface of the coracoid. In the acute setting, putting in this synthetic suture with some collagen in it allows for that coracoclavicular ligament complex to heal. In the chronic setting, if this has been going on for 6 months, the healing capacity of that ligament, if you imagine it's been pulled apart for so long, that the healing capacity is not as good. So in the chronic setting, or if there's instability in that shoulder at the AC joint, then I think it is worthwhile to do a ligamentous reconstruction. So this is the final pictures of this guy, and here's the side to side. It's not a perfect film with rotation, but I would argue that it's pretty close, and that's kind of what it looks like. You know, historically, one of the problems with this surgery has been that however you fix it to the clavicle, it weakens the clavicle, and you can have a clavicle fracture, you can have a coracoid fracture. But with this technique, we're using such small little holes that has not yet been reported with this. So I do think that it is something that we'll see more of, and I plan to do more. This is a patient of mine that had also gone through the deltoid trapezial fascia, so another type 5, but in addition, this patient had significant instability where there wasn't, not only does the clavicle go up, but it can go anterior and posterior, and that's what this case was. And so in order to provide more stability for this patient, I did a ligamentous reconstruction very similar to this, where I wove a allograft around the coracoid, fixed it with some interference screw fixation, and then also brought one limb of that graft over the top to reconstruct the AC ligament as well. So here we have the CC ligament reconstruction, and with that same graft, I can actually redo the AC ligament reconstruction as well on the top. So this is what that particular patient's film looks like post-op. So let's see if, oops. So this is pre-op, and then that's post-op. And you can see these tunnels are bigger than that other one, and so this causes me to lose sleep at night more so than what the one with the real small hole through the clavicle and the coracoid would. But so far, so good. Going to finish up with clavicle fractures, and maybe we'll get you out of here and get back to your work a little bit ahead of time. Classically, even when I was in medical school, the dogma was any two ends of a broken clavicle that are in the same room will heal, and I think that that's still true. What the research is starting to show, and I think has been proven, and I think that orthopedic surgeons would agree who've reviewed the literature and started using the plate, is that in certain situations you can definitely improve the functional outcome of the shoulder if you fix certain clavicles fractures. So 17-year-old kid, right at the beginning of his basketball season, this is his clavicle fracture, and one of the things, I guess, the take-home message for the people that would potentially refer to me would be that the indications for surgery for a clavicle, and that is displacement. So this tip of that bone is supposed to fit in there, and so that's, based on this measurement, was basically 3 centimeters. And the literature would show us at this point in time that we know that we can improve shoulder function if the initial displacement is 2 centimeters or greater. And by improved function, I mean with surgery. So this kid was a young kid. It was his dominant shoulder, and because there was greater than 2 centimeters of displacement based on literature, he and I and his father discussed surgery versus non-surgery, and he elected to proceed with it. This is called the Sanka view. This is how we get the clavicle x-ray. It's basically an AP of the shoulder, but with just a little bit of a cephalad tilt so that we really get a real good image of the shoulder. So this is one of the hallmark papers. This came out in 2008. Journal of Bone and Joint Surgery is probably our top paper in top journal in orthopedics. And what I would draw your attention to is this is the Canadian Orthopedic Trauma Society. And in Canada, the government doesn't pay for things unless it's proven to work. And this is coming out of a Canadian registry. And in the U.S., there's a lot of things that we do that aren't as rigorously tested as what they are, I would argue. So I think that the fact that this paper comes from Canada gives me more, tells me this is the real deal, basically, for lack of a better word, that I believe what they say because of their cost control and their healthcare system. So this is basically, I treat this like a fibula fracture in the ankle and basically make an incision across the top, put the ends of the bone together, and then fix it with a plate. One of the reasons why some orthopedic surgeons are reluctant to do this and why falling back on that mantra that any two ends of a clavicle fracture that are in the same room will heal is nice is because underneath the clavicle there are lots of important things, a very large vessel, the subclavian artery, and also the brachial plexus. So you can imagine drilling, and then also the lung too. So complications that have been reported with this have been having a pneumothorax, or a drop in a lung, have been penetration of a vessel, and that obviously can cause a lot of bleeding. I like to I'll sneak my finger underneath that, and so I'm drilling into my finger. That gives me proprioception, so I know exactly where it's going, and then also I can feel it. I've done probably 8 or 9 of these since I've been here in August, and they've all gone very well. And I guess the ultimate question is if I had one, would I want mine fixed? And I would. What's the downside of this kid if he didn't have it fixed? It would heal here, and you can see that his shoulder is much shorter now because the clavicle serves as a strut to strut the whole arm or that forequarter out. You get earlier fatigue if it's short. It changes the scapular dynamics and kinematics, and so you're more likely to have shoulder impingement and other things like that. So if I broke my collarbone or my clavicle and it looked like this, I would ask one of my partners to fix it for me. That's it. That's the crew there. So, happy to answer questions. Otherwise, we'll get you back to work a little early, maybe.
On the clavicle, does it matter lateral, medial, third?
Yes. I try not to fix the medial ones because the closer you get to the center, the closer you're getting to the mediastinal structures, and it's more difficult to get fixation there. This literature is for mid-shaft clavicle fractures. If you have a lateral fracture, I'm going to see if I can get my PowerPoint up. Is that possible? If you have an injury out here, we can put a plate that comes all the way out here, and that works really well. And the other thing you could do is you can slip this into it to provide additional fixation, because a lot of times these are, if they fracture lateral to those coracocollicular ligaments, this is like it becomes like a separation. Because the ligaments hold this piece down, but not this piece. And so you can put a plate on there and then incorporate this fixation as well. And so it's kind of a clavicle / AC surgery. So I like doing the mid-shaft ones and the ones that come out all the way to the shoulder. But the closer you get to the mediastinum, the more you have to worry about the trachea and things like that. And I try not to fix those if possible.
Still 2 centimeters, even the lateral? Still 2 centimeters, even if it's lateral?
But that literature hasn't been totally borne out yet. But if it's comminuted, and oftentimes these ones out here tend to be comminuted and displaced superiorly, and so it can threaten skin. And if it's a real bad one, I would favor putting a plate on it and then putting this kind of construct to help hold it down. But the 2 centimeter displacement or shortening only has been proven on the midshaft. So.
I'm not sure if it's in the PT, the follow-up. And if and when they do fail, is it from the suture pulling free, or is it a new tear?
The most common, the most common cause for this to fail is that the quality that's the tissue is not good enough, and then it won't heal because it'll pull through the suture. That's the most common. And basically, what I try and tell patients, I try and counsel them that, you know, the risk of this failing is correlated to the number of birthdays you've had. So your rotator cuff when you're 20 is really, really good tissue, and if that tore and you put it back, you've got an excellent chance that it's going to heal and that it's not going to re-tear. When you have a massive tear in somebody who's 90, the chances that the quality of the tissue is good are much, much less, and so it's less predictable as the quality of the tissue deteriorates. So that's why looking at the quality of the tissue here is really important. So this is pretty decent muscle, but there's some fatty infiltration here. If that fatty infiltration had come down all the way to below this line, research would suggest that it's very poor healing capacity, and that fatty infiltration may not reverse. So in general, the older you get, the more likely you are to have a re-tear or a failure to heal or for it to pull out. And that's something that's a conversation I have with every patient that takes the operating room for a rotator cuff. You can imagine my frustration and my patient's frustration if I put them through a painful surgery and then it doesn't work. So. All right, well, thanks for coming, everybody.